And to take this conversation further, our lives have been changed and challenged by COVID-19 as South Africans reflect on the glut of loss and suffering caused by the pandemic almost a year after the first lockdown came into effect. What more are we learning about the deleterious effects of this disease? Let's bring in a better mind to help us understand the complexities of COVID-19. Professor Salim Abdool-Karim is the director of the Center for the AIDS Program of Research in South Africa, or CAPRISA. The professor joins us now via Zoom. A very good morning to you, Professor.
Very good morning to you, Desiree. Good morning to all of the viewers.
Good to speak to you. You said, we're pretty surprised, you said in an interview this morning that your contract as co-chair of the Ministerial Command Council came up on Tuesday and you opted not to renew. At such a time as this, when cutting-edge research is being produced at speeds never seen before, one would imagine a person such as yourself wants to be in the thick of things. Why did you walk away?
So when I agreed to taking on this responsibility a year ago, I did it on the basis that I will serve our country for a year. It's not a contract, it's a voluntary thing. There's no payment or anything involved. We do it as a labor of love. But when you do this job, you have to give it 100%. The public, our nation, our country deserves a chair who will be 100% committed to dealing with COVID. I have been for the last year. Exactly 1 year later, my term came to an end, and I thought it's time now for me to continue my other work. I have enormous responsibilities that I have put on hold for a whole year. I can't continue to neglect them. My work on HIV is at a critical stage. I have huge commitments at 5 universities. I have to go back to meeting them. That doesn't mean to say I'm no longer, going to care about the COVID situation in our country. I'm always available, but I've got to concentrate now, and somebody who's leading the scientific response needs to give it full attention.
I imagine that your excellent scientific analysis will be sorely missed, but I understand what you're saying. But you also, in that conversation, dispelled the narrative of an imminent third wave as we approach the Easter holidays. With the attendant decisions about to gather or not to gather, how does one discern the proper data?
So we look at the situation in the country as a whole and in each of the provinces, and we even look at it at district level. And we look at the testing, we look at the number of cases, particularly the rate at which new cases are occurring. We look at admissions, and we look at death. So we look at all of these different indicators, and together they create a picture for us. And what we are most interested in is what we call the trajectory. What is the trend? What's happened over the last week or two? Because that might influence what's going to happen over the next few weeks. And if you look at the situation, since we came to an end of our second wave, we have been very consistently at a level of low transmission. And that applies across all the provinces, applies for the country as a whole. There will be a few increases. We see a little bit of a blip in the Northern Cape, a bit of a blip in the Eastern Cape. That's to be expected. That's how this virus will continue to simmer over time. What we want to know is, are we getting to a point? Is the trend suggesting that a third wave is imminent? Is the trend suggesting that we are going to go into a situation of reaching the threshold for a third wave? The threshold is quite high, and we're quite far away from it. And as it stands right now, the indicators are good. The important thing is to keep it that way, because with just one weekend where we will have mass gatherings, we can undo that situation and create and ignite a situation where we could go into a third wave. So our task right now is to make sure that our behavior protects us and keeps us in a situation where we are not at risk of a third wave rising rapidly after this festive period.
So we know tomorrow, the 26th of March, will be a year since that day last year when the president announced lockdown level 5. A year down the line, and we're still evolving our understanding, what would you say are the biggest lessons South Africa's scientific community has learned from COVID-19 in the last 12 months?
Oh, I think there are many lessons. I'll just quickly rattle off just a few from my experience. And the first is you've got to act decisively, you've got to act quickly. Even small delays in this epidemic can lead to lots of deaths. The second is you've got to ensure that your scientific information, as best as is possible, is available to guide the response. And I've been very proud of the fact that we've had the opportunity as scientists to communicate that science, to share with the public everything we understand so that it decreases anxiety. And then the third for me is that we have to understand that we know little about this virus. We've only been around for just over a year. For example, a few months ago, if you asked me, what happens 2 months after this infection, I wouldn't have even known about long COVID. Those are things that are new and emerging, and we're learning as we go along. And so it's very important that we continue to learn, because we now know so much more about this virus than we did a year ago. When we instituted drastic measures to control interactions to reduce the spread of this disease, what we know today is very different. And now we have a lot more tools at our disposal. The most powerful of which is vaccines, the second most powerful of which is our behavior, and the third are all the different rules that help us restrict and prevent super spreading events. So there are many things that we have learned, and we have learned how to use them more effectively now.
Are we any the wiser about the body's immunity?
So as we've understood this disease, we didn't quite grasp it initially. So we go through stages in this disease. I'll just quickly describe it. So the first is when you are exposed, the initial virus starts growing, usually at the back of the throat. And as this virus grows, it then gets into a stage where you become infectious. But you are infectious, in other words, you're now, as you breathe, cough, sing, you're putting out these little droplets with the virus in it. And that we call the asymptomatic or pre-symptomatic period, where you are infectious, you're infecting others, but you don't know that you have this virus and you're not sick. Then about 5 to 7 days after that exposure, you then become sick, and a small proportion becomes sick. A lot of people don't even know they have the virus, they just recover. Of those who get sick, they develop a very severe immune response, and they normally are positive for about another week. That immune response becomes the big problem thereafter, because the virus is cleared usually after about 2 weeks. But that immune response, what happens is that the body thinks this virus is still in your little alveolar sacs in your lungs. And what happens is that it becomes filled with pus. And that pus prevents you from exchanging oxygen. So now you don't have enough oxygen. You're breathing, the air is going into your lungs, but it can't exchange that. And so now we've learned how to deal with that, with CPAP, with oxygen. Oxygen is one of the most powerful weapons in this disease. We also know how to use steroids now. We're learning all kinds of things about how to control this disease. But once you recover, and the vast majority, over 99% of people recover from this disease, that recovery is now what we're learning a lot about, because now you can have long-term sequelae. We're also learning that you can get reinfected. So there's a lot of things we are now learning about in this disease.
Prof, let's speak about India having detected a so-called double mutant variant of the novel coronavirus. What more are we learning about this?
Yeah, so the variants, just this morning, the New England Journal of Medicine published an article which Professor D'Oliveira and I wrote about variants and what we've learned. So we've learned 4 key things. The first is that several of them can spread faster, including our own 501YV2 variant. The second is some of them cause more severe disease, as we've seen with the B117 variant. Evidence from the UK shows it's associated with higher deaths. Our own data suggests that it's also associated with higher deaths, but not clear as to what's causing that. The third is that we're also seeing that some of these variants can escape natural immunity. They cause reinfection. And then the fourth is we're learning that vaccines may not be as effective against variants as they are against the previous viruses. The full implications of those data are not clear at this stage. But we see how, for example, with vaccines like the AstraZeneca vaccine, the Novavax vaccine, and so on, if you take just the Johnson & Johnson vaccine, the efficacy is lower in South Africa than it is in the US. So we are seeing these effects now. In India, they released their latest results of their genomic analysis, and they used a curious terminology called double mutant. We don't use that terminology. It sounds more exciting than it really is. What they're just pointing to, that they have a variant that has two changes in the receptor binding domain. That's the part of the virus that attaches to the human cell. So the B117 variant that was described initially in the UK has one mutation in that position. The variants that they described in India have two mutations at that point. And then the variant we've seen in South Africa, the 501YV2, or the P1 variant that was first described in Brazil, those two variants have three mutations in the receptor binding domain. So we're going to see all kinds of variants emerge. That's just, viruses mutate. That's just how they do. And all viruses do. It's not unique to the coronavirus. But we don't worry about most of these variants. We really worry about those that lead to changes in that part of the virus that attaches to the human cell. And that's why this announcement from India isn't important to note, but it's not any reason for any concern.
So, Prof, it's the predicament of the variants against the vaccines. Have you taken a vaccine? How does an ordinary South African decide on which vaccine to prioritize?
So the way in which the government has been functioning in terms of vaccines, they have asked the Ministerial Advisory Committee on Vaccines to provide advice as to which vaccines should be prioritized. And based on the available evidence, a certain number of vaccines have been recommended by the Ministerial Advisory Committee. So the government then proceeds to assessing all of that information and makes the decisions as to which ones they buy. But any vaccine that the government is distributing and providing meets our minimum requirements. And so they are all more or less equally as good. So there's nothing to really choose between them. You can take one or the other. As long as they have all been licensed by our regulatory authority, we can be very confident. Also, there's nothing to be gained by choosing this or that, because we will be using many different vaccines. It's very important that we use a multitude of vaccines. And the reason for that is that if there's any issue with production, or if there's any issue with safety or longevity of the immune response, we don't want to find that, we've chosen just one and that we now have this problem. We want many different vaccines. So people will get a vaccine and they won't really have a choice. I don't think in what vaccine to choose. Whatever vaccine is available at that time, they can be confident is effective. If we look at right now, we are rolling out the Johnson & Johnson vaccine. That vaccine has been shown to be very effective in South Africa. It was tested right here in South Africa. And that vaccine has been shown to be safe and effective. And when I myself got my vaccine, I was expecting to get a whole lot of side effects, because the side effects are pretty standard. You get a bit of sore arm and you get a bit of chills and so on. I got nothing, and I was a bit surprised. But it's true that most people just won't get symptoms, but a few people will have some of these effects. That's just the vaccine working. That's how it works. It applies to pretty much any vaccine. It's not unique to the coronavirus vaccine. So my advice is, that as we go through the phases, right now we're in phase 1 for healthcare workers, we're going to go into phase 2 pretty soon, and that will provide vaccines for the elderly and for those with comorbidities and essential workers. When your turn comes up, please go and register and get your vaccine and take the vaccine that's being given to you, because you have the confidence of our scientists in giving the government advice that this is a good vaccine to use.
Trust me, Prof, South Africans can't wait. It's just there's that delay that the Minister of Health was talking about that's impacted by global markets, but we all want a vaccine. But just in terms of the conversation on vaccines for children, how far is the scientific community in terms of this conversation?
Oh, that's a very important question, and one that's being addressed as we speak. So all of the vaccines that have been tested only in adults. We have no information on the safety and the efficacy of the vaccine in those below age 18, for most of the vaccines. So we cannot give this vaccine to young people, to those below 18. They are only intended for those above 18. But at least 3 of the companies that I am aware of have already started or in advanced planning for their vaccines to be tested in young people. The furthest along is a vaccine being made by a company called Moderna, and they have started trials in children already. And we will see all the other companies do that. Children are a lower priority because very small percentage of children get severe disease. But when children get that severe disease, I mean, it's such a special disease, it's got a new name even, called multi-system inflammatory disease. So this new disease that we see with the coronavirus in children is rare. And so children will get vaccines, but only after the adults do. So we can anticipate that children will be lower down on the list, and only once the vaccines have been shown to be safe and effective in them.
There's also the issue of COVID-19 fatigue. We spoke about it being a year later. What's your level of concern regarding a spike in case numbers?
So it's been, for me, one of the very important approaches to dealing with responding to COVID-19 is that it's a combination. It's a combination of government-imposed restrictions and our voluntary individual behaviors and how we change our behaviors to reduce risk. And every time when we're trying to reduce our chances of going into a wave, we balance those two. We balance what the government needs to do, and we balance it against what people voluntarily will do. So our hope is that by now, people really understand and have come to terms with the fact that we've got to maintain social distancing, masks, and so on. That's not something new. We all are familiar with that. Problem has been that human behavior also involves some degree of complacency. And we see that as the alert levels go down, so too does the mask. And when I do my morning walk, I see that now. Under level 3, everybody was, very fastidious, very careful. They wore their masks very carefully over their mouth and nose. As I walked, I would see the occasional person. I'd stop and educate them, say, let me explain to you how you need to do this. But nowadays, because we're on level 1, people think, nothing to worry about. They couldn't be further from the truth. The reality is that we depend on individual behavior. And so we ease restrictions to let individual behavior control the spread of the virus. The less we individually act to control the virus, the more we have to impose restrictions to do that. So it's a fine balance. And as I look at our situation right now in the epidemic, we are in a very good position. We are in a situation of low transmission. We just come out of a second wave. We're dealing with about 1,000, 2,000 cases per day. We're less than 5% positivity. Our admissions are showing a clear downward trend. Deaths have just a bit of stabilized, but we'll keep an eye on that because it's been steadily going down. Yeah. So we are in a good position. We need to ensure that we do everything, each one of us, to keep it that way, to make sure that we wear our masks, we keep our social distancing, we sanitize our hands, we do all the things to maintain low transmission. Because if we don't, we create the sparks, we ignite the possibility that the cases might rise again. And that's what we want to avoid. We want to keep it in our current situation.
Prof, we want to let you go now, but the gist of our conversation has been that it's been a year of change, pandemic-led change. In some of the areas, people will go back to their normal lives. But just in terms of the healthcare profession, what are some of the changes that you envisage will stay led by this pandemic?
I think for me, one of the most important things is that we've learned that we've got to be prepared. This is not the first pandemic we're dealing with. We've dealt with many pandemics before. We've dealt with local epidemics like listeriosis. We've dealt with HIV, which is a pandemic. And the coronavirus has been a wake-up call because it has told us we need to be ready for the next one, because we are quite likely to see many more pandemics coming through, whether it's coronaviruses or influenza or other kinds of viruses is left to be seen. But preparedness is important. And that preparedness is about ensuring that we have the surveillance systems in place, that we are monitoring with all our laboratory tests for people coming into our country, people who get sick in our country. We are monitoring what the infections are, and that we have the health system capability, whether it's beds, ICUs, CPAPs, whatever it is, we have that capacity. And to me, the most important thing is we have a trained and committed healthcare workforce, because ultimately that's who we depend on for our lives. That's who we depend on to protect us. That's who we depend on us when we get sick, to keep us, from dying. That's who we depend on to care for us and make sure they make the right decisions in the way they treat us. And so to me, it's that continuum of preparation that this pandemic has taught us, that we need to use what we've learned, draw on those lessons, and be better prepared for the continuation of this pandemic and for the ones to come.
Let's thank you for your time this morning. Hope to speak to you again soon.
It's a pleasure. Thanks, Desiree.
Professor Salim Abdool-Karim is the director of the Center for the AIDS Program of Research in South Africa, CAPRISA. What are your thoughts about that conversation? It leads us to that poll we're running this morning where we asked you, should the lockdown level in the country be changed? Let's take a look at some of your responses.